Hi, good afternoon. I'm Brad Waters, the Executive Vice President of Science and Research, and welcome to our COVID-19 Research Town Hall. It's been a couple of months, actually, since we've had a town hall, so we thought it was time to do so again. We've had several of you reach out to us with new questions, and of course, 2 months is a long time in a pandemic, even with the holiday break that was in between. So we've got a number of areas that we want to cover today. There's been, of course, many developments since that time, the most exciting of which have been the approval and the initial launch of the vaccines. We've seen the approval of both the Pfizer-BioNTech vaccine as well as the Moderna vaccine, and UHN has been playing a key role here in the province in the initial inoculations of vaccines. Some very good news around long-term care here in Toronto, and where UHN has also played a role, and also lots of frustration around now the delivery and the overall schedule. But I think it's important for us to remember too that these vaccines are here at a time frame that certainly exceeded even the best estimates when we were thinking about this last summer. So it's a difficult time right now. Despite the fact that the vaccines have rolled out and of course given us hope that the end of this pandemic may be in sight, we're also in the middle of a second wave that is again devastating our healthcare system and also affecting our population in very asymmetric ways, and some parts of our population, of course, bearing the brunt of that second wave. It's had impact in the hospitals and some of the activity that's going on in the hospitals, and the preparation continues around that. So we're really fortunate today because we've got a couple of invited guests that are going to be able to speak to us both about the modeling that's being done at the provincial level and helping guide the decisions that are being made. So Dr. Beata Sander here from UHN is who sits on that modeling table and who also does this as part of her research, and she's been a very important part of helping guide the government and some of the decisions that they're making and getting the data at least to them to help them make those decisions. So we'll hear from Beata, and then we also have Dr. Emily Musing here, who's our head of our pharmacy and has been in charge of the vaccine rollout and all of the work going on behind that. So it's been a huge amount of work for her and that team, and I'm really appreciative that she's also taken a bit of time out to join us and share some of the updates around the vaccine. And Harry Janssen is here again. We'll continue our updates on clinical research. This is an area that has, of course, is most vulnerable to changes in hospital activity associated with the second wave. And then we'll get to our Slido questions as usual. Okay, so Beata, I'm going to hand it over to you. Again, thanks, and very pleased that you're able to share with the research community some of the work that's going on in your group and the larger modeling team.
Thanks so much, Brad, and thanks for having me today, talking a little bit about modeling and the role modeling has been playing in pandemic response. That's not just about my own team, but also around science table and modeling tables and all these kind of bodies that are now established. Let's say modeling has informed Ontario policy from the very, very beginning, and a bit more informally, this was the very first model we have done that went into that first briefing about 10 months ago now. I'm still shocked when I look at it at what we were told what the ICU capacity is now, but either way, so we kept going. So I think initially it was more a kind of informally, there were science briefings and there wasn't like a rhythm. I think now we go every 2 weeks. And so we continue to basically feed into the science advisory modeling consensus table science briefs that they need us every second Thursday. Next one is in 2 weeks. So usually every second Thursday. So I want to start with just talking a little bit about this overall process. Maybe just for those who don't know, there are several tables now, so it's not quite on the slide, but so there is a science advisory table, who partners with 3 other ones. So there's an evidence synthesis table that kind of does literature reviews, rapid reviews, feeding on specific topic, feeding into the science table, and then on to decision makers. There's a very new behavioral science table. So that one's mostly around behavioral science, especially focused on vaccines right now. And then there's the modeling consensus table. That's the one that I'm co-leading or co-chairing, which is modelers, decision makers, epidemiologists. So it's quite a range of people that kind of comes together every week, and we discuss all the different types of models and latest evidence. And so all those different tables feed into the science table and then into decision making. So just very briefly in terms of process for the science briefings that you kind of see, like I said, usually it's every 2 weeks, and then sometimes there's like something happening and they're like, oh, we need it this week instead of in 2 weeks. But so the ideal process is there's kind of like the off week and then there's on week. So this week, for example, is the off week. So that's where we kind of start planning of what's going into the next brief next week, Thursday. So last night we met just talk about kind of what is the broad topics that we want to include. And if you have seen it, there's usually kind of a bunch of like standard slides in the beginning that's kind of describe the situation we are in right now in Ontario, talking about number of cases, positivity, long-term care. So they are all kind of standard. And then there's usually some other kind of topic at the end. The last one was around variants of concern. And so there's always something in addition to that. So that's kind of where the planning comes in, where we get people together, think about what's all the stuff different scientists are actually working on, what's the evidence we need to pull together. And so just kind of when we start drafting slides, usually the first set has to be ready around Monday night. And then that's already then going into the on week. So Monday night, maybe slides ready midday Tuesday, and then basically presenting to the main tables, which is the science advisory table and the modeling consensus table, because there's always a very heavy modeling component in those presentations. And that's mostly, it's really for consensus, especially on the modeling side, but all the other topics as well. So we want to make sure that all the scientists that are sitting on those tables agree with kind of how we went about making predictions and all this kind of stuff. And of course, feedback. And after that, there's usually quite substantial revisions, a lot around language and kind of tweaking it. But then at the same time, it kind of starts already being presented at different tables. So one of the tables we usually go is the health coordinating table. It's kind of the highest kind of table making decisions. But there are other tables as well. So it kind of depends on the topic, where it goes public health measures table or any type of other kind of tables that make recommendations to the government. And then as we kind of get closer midweek, then there are ministers' briefings. There's cabinet presenting same to cabinet, caucus, and then they're kind of we refine every time we present a little bit. And then Thursday, last one is when Steny presents to the public, basically. So that's kind of how it works in terms of process. And so in terms of science, and then for this, I want to focus on what my team is doing in terms of modeling. And you have seen probably all the kind of predictions. So it's usually kind of looking at what are plausible case trajectories for the next month. Based on that, we look at predicting hospital and ICU occupancy, and then also provide some context, especially on ICU occupancy, kind of what does that actually mean. Next slide, please. So if we think about what is a plausible case trajectory over the next month, there are many different aspects that go into it. So one thing is model prediction. So we have our own model that we run where we simulate individuals in the community, and then so they are being infected, kind of where we are now, having similar type of interventions, and then kind of predict that forward. For the science briefs, there's not just our model, there's also 3 other models, one from McMaster University, one from the Fields Institute of Mathematics at U of T, and one from Public Health Ontario. So we run 4 models, look at the predictions, and then kind of come up with a range. We also always look at experience in our peer jurisdictions, where we choose peer jurisdictions based on the healthcare system, their economy, and other type of criteria. And then we look at what is the current Ontario case growth. So we kind of look at what happened over the last 2 weeks or so, looking at 3 and 7 day average in new case growth. And so based on all this, we then kind of look at what type of trajectory maybe are we likely going to be on over the next little while. So what I'm showing here in the figure on the right is the example from January 7. And we all know it actually turned out quite different because something else happened. So we went into the stay-at-home order. So usually our predictions precede this type of announcement. So we kind of don't really know quite what's going to happen. But so this would be an example where things were actually turned out a little bit different because we're a bit on a decline right now as opposed to seeing stable or increasing case numbers. But so those are other considerations that we try to take into account, but it's really, really hard. So like any type of major interventions that are announced after we make our predictions, and other things like variants of concern, where I don't know. We know there is community spread in Ontario. We don't know what the extent is. We don't know when it's going to take off. So that's in terms of case trajectory. And then next slide, please. So we use these case trajectories and then feed them through what we call it's a microsimulation model that's kind of recreating the Ontario healthcare system, not the whole healthcare system, acute care, and kind of looking at individual patients being admitted to hospital where they could go straight to the ward or straight to the ICU, or first to the ward and then to the ICU, or they may be sent home because they are not as severely sick. And then if they are in the ICU, they may or may not be ventilated. They could die at any time during the hospital stay, or they would be discharged once they recover. And so this model keeps being updated on Ontario data in regular, about monthly intervals now. So we feed basically our case trajectory to the model, and that's how we come up with our ICU occupancy. And you see, because the cases that we thought would happen would continue to increase, so we also predict that 2 weeks ago that hospital occupancy would increase. So that's not the case. But what you also can see is that usually from number of when someone is reported as a case until there is a change in ICU occupancy, that takes about 10 to 14 days. So there's a little bit of time. So usually from the time we make our predictions, the next 10 to 14 days cannot change. So it's not going to change. So those predictions are very accurate because they're based on the cases today. But then when you go further out, it might not be quite as accurate. So it depends on the scenario. We also put in here what we think is the maybe one back just for 1 second, the 150 bed occupancy limit. So that is 150 after, if it's more than 150 beds for COVID-19 patients only, that's when we have to start thinking about change in services and reduction in terms of surgeries and procedures, any type of elective admissions. Okay, now next one. This is an example just kind of in terms of providing context, because the predictions generally only focus on COVID-19 patients, but we know that there are many other patients that are non-elective admissions occupying ICU beds. And so this shows much better what is going on, for example, in the ICUs across Ontario. This one is from January 4th. The majority of hospitals had 2 or fewer beds available. And so that's a very critical situation to be in. We've also in the past kind of talked about occupancy in general, and that you should never run an ICU at 100% occupancy, and probably never more than 85%, and ideally a little bit lower. So kind of providing that type of expertise as well. And last slide, I think. Yeah, so there are other applications and extensions, and I think in the interest of time, I won't be talking about it. Maybe just to mention, we also been looking at what is the health impact of curtailing procedures and surgery. So from the first wave, what does that mean in terms of wait lists and then health outcomes for cardiac, vascular, cancer, and ophthalmology surgery. And I think this is it, except saying thank you to the many people that work on all those different types of questions. And yeah, I think That's it. Thanks for listening.
Terrific. Thanks, Beata, and thanks for all that work you're doing. I think, for those of you that are interested, many of you will know that much, if not most of all of that modeling data is released openly to the public. So you can go on to the Science Table website and look through the modeling predictions that are presented on those bi-weekly updates. And this is something that's guiding, obviously, the province, but it also is guiding the hospitals. And the predictions, particularly the kind of work that Beata is doing, are very important considerations around what the hospital is doing in terms of pulling back around scheduled care, surgeries, and so on, which has happened in the last couple of weeks. Okay, so thanks again. We're going to turn our attention now to Dr. Emily Musing, who is one of our vice presidents in the clinical vice president. She's also the chief patient safety officer, and part of her portfolio includes the UHN pharmacy program. So that's become an extremely busy area. She's leading the distribution of the vaccine for UHN staff, but also because of the role that UHN has played in being asked to set up vaccination centers, has also been key in getting all of that going. So Emily, over to you.
Thank you, Brad. So full disclosure, I am not a doctor, but I'm very happy to be here with you today to provide you with an update.
Today you're a doctor.
Thank you. To provide you with an update of UHN's vaccination strategy. So you may or may not know, but our strategy really involves a multi-pronged approach. So we do have mobile teams under the leadership of Brian Hodges and Shran Isaacs, who have successfully provided Moderna vaccine to residents as well as some staff and essential caregivers at our 77 retirement homes, 87 long-term care homes in our area. And they will be returning to the site starting on January 28th for second doses for these individuals. We are also supplying Moderna for vaccination to northern communities. Orange is going up there to vaccinate like Sioux Lookout and Moosonee. Now, with respect to our Pfizer vaccine, we've opened 2 clinics. One is the Michener. This was opened December 14th as one of 2 pilot sites in Ontario. It has 9 vaccination bays, can provide up to 500 doses a day. And in fact, the learnings that we had from opening of this particular clinic were put into a playbook, which was then shared with the 17 other hospitals in Ontario that then received vaccine after us. The second clinic that we opened was at Mars. So this opened January the 5th. It has 12 bays, allowing us to vaccinate approximately 1,000 doses per day. So based on availability of vaccine supply, we actually have the capacity right now to be open 7 days a week, 12-hour days with regards to these 2 clinics. And we also started looking at a potential 3rd clinic at the Toronto Western site with the BMO tower. So you'll see from the dashboard, and the number changes almost by the minute with regards to the number of doses. But in fact, we vaccinated over 8,000 doses at the Michener, over 4,500 doses at Mars. And while our initial focus was on long-term care staff, we were then able to expand to hospital healthcare workers. So our current breakdown shows that approximately 36% of doses we've given out has gone to long-term care, while 64 have gone to hospital healthcare. Now, I need to ensure that you understand that when it comes to hospital healthcare within our clinics, we are responsible for UHN, as well as Toronto Grace, Women's College, Sick Kids, and Mount Sinai. But with regard to UHN staff, the number that we have vaccinated now, it's actually even bigger than that. I just got out of a meeting and we have over 4,000 UHN staff that have received vaccinations. And then we also got some preliminary data out of COVAX, which is the software program that is linked to the booking system and registration through the ministry. And we can look at UHN staff, or at least people that have identified themselves primarily with UHN, who have gotten their vaccinations from Michael Garron or South Lake or some other clinic. And it shows that when we add those numbers, greater than 5,000 UHN staff have received vaccination. So the other thing that we've done with Pfizer is we've actually provided about 400 doses for vaccination at Bickle. The reason for this is it was in response to many COVID outbreaks that have occurred at that site. And these doses were used to vaccinate both patients and staff in an effort to avoid further outbreaks at one of our UHN sites. Now, the thing that's on everyone's mind, on January the 15th, Pfizer announced that they needed to pause production lines in order for them to expand their manufacturing capacity. So this delay is expected to impact us for approximately 2 to 3 weeks. So in fact, we are not receiving any new supply of Pfizer vaccine next week. We were anticipating that we should have gotten 3 trays. We were getting nothing. So in response to this decrease in vaccine supply, the ministry came out with new directives. So at this time, we've been asked to pause on the provision of all first doses while continuing second doses for individuals who received the first dose at one of our sites. So we're also being asked to look at moving the second dose from the original 21 days to 28 days in order to preserve vaccine. So I just want to note that Pfizer's product monograph does allow for a range between 19 to 28 days between the first and second dose with no change in efficacy. We are looking at our supplies now to determine at what point we need to move to 28 days. So anyone who is impacted, no one this week, anyone that's getting their second doses this week are moving forward as per usual. But starting next week, we're going to look to see who needs to be moved, and anyone who is impacted and is moved to 28 days will be contacted individually by email and will be informed of their new booking date and time. So I'm just going to ask to move to the slide with regards to the vaccine groupings. So in the meantime, we have created definitions to try to identify priority groups for receiving the vaccine. That's what you see put up right now. So we're also in the process of creating an online registry for anyone who's interested in receiving the vaccine. So once the registry is open, it will take you through a series of questions which will stratify you into one of these priority groups as shown. So, and then once we receive more vaccine, hopefully 4 first doses, we will then use the registry to invite individuals, starting with those in group A, to book an appointment for a vaccine. And then once all of whom are interested in group A have received their vaccine, we'll move on to B, then C, then E, so on. And the online registry link will be accessible once it is available. It's not available yet. Will be accessible 24/7. There's no need to rush to register because the date and time that you register doesn't determine that who will be asked first to book an appointment. The slots for vaccination will be available based on the order of the groups and availability of vaccine. And reminder, we have no vaccine for next week. So when we are able to put out the link for this registry, we are unable to book. So we're just collecting information at this point. I think I'm going to stop there, but I'm happy to answer any questions.
Thanks, Emily. We actually do have a couple of questions from our Slido page for you. So the first question is, given the previous communications, we thought that all of Team UHN would be vaccinated by mid-February. But with the vaccine delays, is there like a new time target for all the groups to be fully vaccinated?
Yeah, thank you for the question. I can just imagine how anxious people are right now. There certainly are a lot of unknowns. The time by which we are able to vaccinate individuals will be totally dependent on supply at this point. So as I said, at this point, what we've been told is that the delay will impact us by 2 to 3 weeks. So initially we were anticipating that, we could vaccinate 1,500 individuals a day given supply. And in fact, if we had been able to open up BMO, we would have been able to do 2,000 a day at the 3 sites. So once we receive vaccine, we will ramp up as much as possible to get as many people vaccinated through first doses and finish off second doses. I think once we have vaccine, the description that Kevin has given, which I agree with, if we were able to actually run at full capacity and we had supply, we could potentially do all of UHN basically within the week. We're just really waiting for supply at this point.
Thank you. So I'm going to read the next 2 questions together, given they're both about having the second dose. The first question is, for those who are vaccinated at the South Lake location, will their second doses proceed as scheduled? And then secondly, if any initial dose vaccinated staff have had positive COVID results, or have had to self-isolate since, how would you advise them to go about receiving their scheduled second dose?
So I'll answer the first part of this first. So I understand that there are certain individuals that took advantage of the opportunity that we received to go to either South Lake or to Michael Guerin even for their first doses. So if this is the case, those hospitals will do exactly what we're doing. They're in the process of looking at their supplies and volumes, and they're making decisions with regards to when they need to move people and if they need to move people to 28 days instead of 21. Should that be the case, individuals will be contacted by those hospitals. So if you have a date coming up for second dose, prior to that date, you will be contacted and told if you need to change to something other than the original booking. So that's all I can say, because I'm not sure where each of those hospitals are in their decision-making process. I'll answer the second question, which was linked to if you receive COVID positive results, or if you need to self-isolate, what should happen. So this does happen, and in fact, it has happened to some individuals who were scheduled to come in for whether for a first dose or for a second dose. Obviously, if you are required to isolate, please do so. Maintain your quarantine. Do not come in for vaccination first or second doses if in fact you need to be quarantined. If it is your first dose and you need to be quarantined, please let us know, and then we will make sure that we put you on the list again, so that we don't assume that you have received first doses. If you have received your first dose and are supposed to get your second dose, same thing, let us know. The intent there is that we will find a way to rebook you so that you can receive your vaccination first or second. We've been working with a variety of individuals who have had to self-isolate, and we're working with them to try to ensure that their second dose can be booked when they're out of isolation, but before the 28-day target that we have reached.
Thanks so much, Emily. Over to you, Brad.
Okay, thanks again, Emily. I really appreciate the time. And for those of you who just saw the presentation there, that is hot off the press. Those new vaccine groupings and the registry system, I think that email hasn't gone out yet, but it's going to go out this afternoon to all users. So it's not only has this been a challenge from a coordination point of view and setting up entirely new clinics and launching the booking systems and managing that, but doing so in an environment where you don't know how much vaccine is coming in every week and so on has been a real challenge. So thanks to you and your teams for getting through that. I think the registry is going to be a great anxiety reliever for everyone. So everyone at UHN will be able to log on and register, and we'll have that information. So we'll know that everyone's on the list at least to get vaccinated once that vaccine becomes available.
Thanks, Brad.
Okay.
Thanks for inviting me. And I just want to mention that Brad was probably the first person that came up with that idea of the registry. So thank you very much for that. Thanks a lot.
Well, you can blame me next week.
No, it's a great idea.
Okay, so let's move to Harry, and we'll get the update on clinical research.
Yeah, thank you very much, Brad. It's been a while since we've talked to you, a couple of months as well. And over time, the Clinical Research Restart Committee has met several times, and some developments have been taking place, obviously. So the update is that the surgical and procedural activities were recently reduced by the clinical activity group, and that led to increased in ICU and inpatient capacity and staffing. So if your research is really related to surgical or procedural activities, it will be affected likely, just by the nature of the research you're doing. And as you might remember, when we encountered the first wave, almost all of the research was kind of stopped, and all of the clinical activities were stopped at the time. Currently, there's a more, I would say, targeted approach where we try to keep as much clinical activity ongoing and also as much clinical research ongoing as we can, basically. So, but obviously, when you're doing surgical procedural research, that will be affected. Overall, the clinical research remains in phase 2, in accordance with the plans that aligned with the UHN clinical activity recovery team. And we were lucky enough actually not to go into phase 3. And for that reason, we also didn't have to move down back into phase 2. So we're kind of in the same activity as before, which is roughly 50 to 75% of the pre-COVID activity, which goes along with the most of the clinical activity within the hospitals. So PIs can still, can I go back one? PIs can still restart studies using the same process as before. And PIs in the clinical research division leads continue to monitor activity to ensure the alignment of that. May I have the next slide? So the goal is to maintain the current activity as long as we can, but we need to be ready to ramp down if needed. And guidance has been communicated to all PIs to plan and prioritize activities to scale back based on similar principles used to prioritize the restart at the time. So that's really depending on how many patients are in a specific trial. Trials with a lot of patients are more difficult to continue than very small trials. Does your study investigate unmet clinical needs? Does the study require a lot of UHN support services above standard of care, from JDMI, pulmonary function test, etc.? And can patient visits be completed remotely? So all of these questions that you might have seen before are of importance again if we need to scale back. We did a survey among all of the PIs, and if you look at the amount of research which is ongoing, it's actually a bit less than 50%. It's 25 to 50% currently, because a lot of patients are not coming to the hospital, and a lot of patients who are in the hospital don't want to be enrolled in trials. So in that sense, the clinical research is still on the lower side, and that's also the reason that in contrast to the overall clinical activities, the overall clinical research didn't have to ramp down yet. So, however, a ramp down would be needed if particularly the ambulatory activity would go down. And we have specific triggers for that. And it really becomes necessary if CARD says that we have to move back the ambulatory activity, and then it's quite important that the PIs know that this has to be done quickly, so namely in a 70-hour time frame, and this would have to be approved by the CRDL. So we've sent communication out to all of the PIs. If you have missed that, please go to the research intranet that you can see here on the left lower side of all of the slides that I'm actually showing, where you can still find it, or call the research team to get more information on that. Next slide. So this is the last slide. So the ramp down planning, the scale back of clinical activity and clinical research could be initiated by the following triggers. So that's really if things get quite sour, I would say, and the ambulatory activity would go down a lot. It's mainly the need to prioritize available resources to deliver care to the most urgent patients, the need to create the flexibility in staffing. In other words, when we really would have to redeploy a lot of people, and the need to reduce COVID-19 exposure to staff and patients, and the need to preserve PPE. So those are rather grim scenarios, and I really hope that we'll never get that far, but if it would be needed, I hope that everyone would be ready for that. Thank you very much, Brad.
Thanks, Harry, and thanks to you and that team. I know they're doing a lot of work that's all around preparation, and it has allowed us to stay open alongside the changes in clinical activity, which is very important. So I'm also holding out hope that all that work won't be needed, but we're certainly glad it's there if we do. Okay, Helen, should we move to the questions?
Yes. And before we move to the live slide of questions, we are going to go through a few themes. And the first theme is about on-site research. And I'm going to ask actually the first 3 questions together first, Brad, because they're all about research activity on site. The first one is, why are research staff still on site during Ontario's shelter-in-place order? It seems hypocritical for UHN leadership to publicly advocate for stronger restrictions and lockdowns while non-essential research is still ongoing at UHN. Given the increased transmissibility of the new variants, is this safe? Second, unlike the spring lockdown, in-person non-essential research is still ongoing. Patients come because we're open. Doesn't this put patients and staff at unnecessary and avoidable risk? And finally, where do we stand with the possibility of having to shut down non-essential research or shifting back to phase 1 of research restart?
Yeah, thanks, Helen. So, let me just sort of address this in a couple of ways. One is, the situation now as far as our understanding of COVID-19 and the understanding of our environment and the safety of our environment is certainly different than it was in phase 1. When the virus first arrived, we didn't know much about how it was transmitted. We didn't know very much about susceptibility of morbidity and mortality. We didn't know the kind of numbers we were going to see in terms of infectiousness, its transmissibility. We didn't know in our healthcare system, around our PPE supplies and the ability of our healthcare system to respond. And so, that's why, the sort of extreme measures of shutting down research and shutting down most of ambulatory care in the hospital, it took place. What's happened now, and in part is preparation for this second wave, is a much more detailed framework, both on the clinical side and on the research side. And as we've talked about here before, we've done this in close collaboration and consultation with our other hospital partners in the city, and around a framework of principles to ensure, first of all, that our staff are safe as a number one priority, but also recognizing that research is an essential activity in Ontario. It's recognized by the government of Ontario as an essential activity. And our patients, and both now and in the future, rely on the progress that we make. So we've been monitoring this on a weekly basis. We have 2 calls per week still at the TASN level to kind of assess our situation. All of the hospitals have remained in a very similar situation and structure with respect to the level of activity going on. And we are still comfortable that our on-site activity at the levels that it's allowed and under all the various restrictions that they're allowed is safe. Individuals are not getting and not transmitting COVID at work. And we're also able to maintain a limited level of activity and research and continue to have productivity around that. So we are following the government directions very carefully. We're working closely with them. We're working closely with our colleagues in infection prevention and control and in health and safety, and we'll make changes when and if we think it's necessary. But at the moment, we've also recognized the importance for all of our staff and their careers and the progress and the research that they're making to be able to maintain to the extent possible that going forward. And so that's really what we've done. We are prepared to do something more restrictive if necessary. We were very worried about the phase 2 or the wave 2 and what that could bring and where cases are in Ontario. So we're monitoring that closely. And if we felt it was necessary from either public health or staff safety point of view to lock things down or shut things down further, we certainly will do so.
Thanks, Brad. So the next 2 questions are about positive COVID tests. So I'm also going to read these 2 together first. First of all, can you tell us the number of staff who've tested positive for COVID-19 at each research institute? It'd be reassuring to know if only a few people have tested positive in my work area. And secondly, I work in a shared workspace setting. The person next to me has tested positive for COVID and no one was informed. Is there any way that occupational health can inform other staff about possible exposure?
Yeah, so we had, perhaps you weren't available for the last town hall. We did have occupational health with us to go through their procedure that they make in terms of contact tracing and isolation and so on when a staff member tests positive. And all of that information is available on the website, so you can have a look exactly at their playbook and the protocol that's used. I'd say it's, of course, this is all private health information. So this is not shared by occupational health when people test positive, but the total numbers are reassuringly low. It's less than 20 researchers across all of UHN that have tested positive, and only I think about half of those people were on site at any time where they may have been considered infectious. So it's probably less than 10, and they're really distributed all across all across research, both in I think half are in sort of the clinical areas and half are in basic research areas. So it's a pretty small number. Those are all community acquired cases. We are not aware of anyone who has transmitted COVID while at work. The occupational health team does do an assessment of every case. They identify everyone who may have been exposed or may have been working with them when they were in an area. And if there's any concern on occupational health of a potential transmission, they will contact those individuals and they will be notified and isolated. But anyone who's not at risk is not notified when someone is test positive. Our facility teams are also notified. They go in and they do an extra cleaning, an assessment of the site. They also work very closely with the safety team to make sure there's no conditions at work that might be a concern, if anyone has tested positive. And I think, those small numbers and the fact that there has been, no outbreaks and that has been contained over the last 10 months is a reflection of the fact that the measures that we have taken have helped create a safe work environment. And I know our staff and the training they have and the attention that they put towards this has helped to create that. So I want to thank everyone for what they're doing. I think our workspace and at UHN, both in the labs and the clinic, is probably some of the safest places to be in the country right now. And it's really the community and people's behavior and the restrictions that they are adhering to outside of the work environment, which is key to moving community transmission lower.
Thanks, Brad. The next question is about wellness. People are tired, scared, and burnt out, and it feels like there's still so much pressure to perform normally or work even more than before the pandemic. How can we manage these expectations of our managers, and where can we go for help? I'm going to first throw this over to Brian Beckett, who's our representative from the UHN Research Wellness Team. Brian?
Thanks, Helen. Thank you for this question and for the many comments that are received on Slido. As far as where to go for help with some of these issues, I'd like to just highlight a few wellness resources that are available to UHN research staff that may help with at least the fatigue and burnout part of this question. I'll start by plugging that UHN Corporate Wellness has a weekly newsletter that you can sign up for by emailing wellness@uhn.ca, where they'll detail what's going on across the UHN in terms of wellness programming. And I want to go over some of their current programming that they're offering, one of which was announced today. They're launching a wellness virtual activities program starting next week. It was announced in this morning's weekly update email. You can check out the wellness page on the intranet for more information about that. There's also the UHN Cares program, a self-directed mental health resource page you can find by following the mental health supports tab in the IPAC COVID-19 site. The BRIGHT program, or Building Resilience Within Institutions Together with Employees, you can check out some of their micro exercises on their site on the intranet, the corporate intranet. There's also some free virtual wellness energizers where you can arrange for wellness staff to join any of your meetings and lead an energizing activity for your team. You can email wellness directly to arrange for one of these energizers. They also have lots of webinars available. There's webinars on healthy sleep habits, healthy eating, and there's actually an upcoming webinar for Bell Let's Talk Day that's specifically on mental health and gratitude. It's being put on by the Toronto Rehab Foundation with Cheryl Sutherland, a motivational speaker who's going to be speaking during that webinar. And I also want to bring up the peer-to-peer support line. The numbers here on the slide. It's an anonymous and confidential resource available to all research staff at UHN. It's a great resource to use. I also just wanted to go quickly over some of the resources that specifically the research wellness team, so Sasha Howell, Shane Harding, and myself are working on. We've been doing monthly contests throughout the pandemic, and staff seem to really welcome these as a refreshing break from work to participate in and potentially win prizes. Our January contest involves a survey in which we ask the community for what they would like to see the research wellness team take on this year in 2021. And we'd love to hear from everyone about this. If you'd like a link to the survey, or if you don't already have one, just let me know. I can send one to you. We're also reviving our wellness meetups program as well. You could consider these to be kind of topic or interest groups, focus groups, almost like mini high school clubs, where a small group of folks will meet and discuss their topic of interest. We've had gardening groups, meditation groups, healthy eating groups as examples. And we also have a wellness hub full of resources for research personnel available by navigating to the research intranet, the COVID-19 preparedness page, and then the wellness tab. And I think for the second part of this question regarding managing expectations for managers, I think, Brad, you have a few notes for that.
Yeah, sure. Thanks, Brian. And just thanks again to you and the team that's been doing all of the work behind the scenes on this. Sasha and Shane, I know you guys are working hard, and this is certainly an important part and one that deserves lots of attention. On the second part, you're right. People are tired and scared and burnt out, and I see it now too. We've got a promise of a vaccine coming and a potential end to this pandemic that gives everyone some hope, but there's a runway before that's going to happen in a major way, and the next 8 weeks are going to be really tough, and I think everybody needs to prepare for that a little bit. I've also seen fuses get a little short recently, a bit extra anxiety, and I fully understand the situation that everyone's in. We're messaging to leaders, to principal investigators, and to managers to be cognizant of this right now, to create flexibility where you can, and to recognize that everyone in our staff are facing all kinds of challenges that we don't see in their environment during this lockdown. We've got lots of individuals with family at home, with kids at home, that are helping their kids get through school during the day, that are working hard at night, and so on. So I know all of that's going on. It is going to be for a limited period of time, and we certainly want to provide that kind of flexibility. So we will continue to message that. We all expect that there will be a tough period to go here. February is a lousy time of the year. At the best of years, it's going to be particularly a tough one this year. So we will make sure that those messages continue to get out. If you feel that that message isn't getting clear, or that you're struggling more, we want you to reach out. You can reach out past your manager if you need to. You can go to human resources. You can come to the research directors. You can come to me, and we're happy to address anything there that we can. And of course, if your burnout or your anxiety is a different kind, if you feel you should get medical attention, you should speak to your primary caregiver about that. Absolutely. They're also, of course, very aware and doing what they can to help treat everyone right now, and to maintain mental health to the extent that's possible. So extremely important topic, and we'll continue to give it the attention it deserves.
Thank you, Brad. Let's move to some live questions. Just a reminder, if you want to join this conversation and discussion, you can scan the QR code that you see on the screen, or you can join us at slido.com and use the event code #UHNRes-COVID. The first question is, South Lake vaccination to research staff was consistent with not wasting vaccine, as outlined in the email from Brad. Media damage control by UHN has unfairly tried to shift the blame to a moral failing by researchers. Can we expect future UHN communications to throw well-meaning research staff under the bus?
Yeah, thanks for the question. And I'm sorry that that communication was interpreted that way. I can guarantee you that it was not intended to be that way. On the Sunday where vaccination was opened up broader than frontline staff, it was done so because of an availability of vaccines that remained for that day after all other slots had been filled. So research and other non-clinical staff were invited for that single day to take advantage of that opportunity. And that was an invitation that came from UHN, and there's absolutely certainly nothing wrong with those that took that opportunity. There has been lots of communication. It has been a struggle around the organizing of the booking and so on. And although the vast majority of staff at UHN have followed those guidelines and done that appropriately, there have been a handful of cases where that wasn't the case, where people shared URLs inappropriately, or came at times where they were not invited. And so any discussion around jumping the queue or anything like that in communication was really just referred to that group. So if that message came through, we apologize for that. It certainly was not intended that way. And there's certainly, if you've listened to Kevin speak at the UHN town halls, he's stood up for research a number of times, and I think if you look carefully at the categories, the A to E categories now, researchers are part of every one of those categories, including A, B, C, D, and E. So we don't distinguish based on role here. It's really around risk, and that's how individuals will continue to be invited.
Thank you. Next question. Going along with the question about staff feeling really burnt out, stressed, and anxious, can we please use sick days as mental health days? I've been struggling greatly, and this would be a great option. Lisa Murphy, are you on the line?
I'm here. Thank you, Helen. I'm here. You can hear me okay?
Yes. Yes.
Thank you. So thank you, thank you for this question. And, as Brian showed earlier, there are a lot of resources available to you to help you with, dealing, with the feeling of being, burnt out, stressed, and anxious. And, I encourage you to explore a lot of the self-care that many groups have put together for you for you to access. And they're all available, as Brian said, under our health services team, as well as the UHN Cares under the COVID links. What I would say too is that, as Brad mentioned earlier, if together with your primary care physician and your support team, it is advised that you might need to explore if there, maybe are different ways to adjust your work, or if you need to take a leave and it's recommended by your physician, please have a conversation with health services or human resources. We can support you through that process.
Thank you, Lisa. Brad, is there anything you wanted to add?
No, I think, I think HR is there to assist with this. I think if you're wondering around whether or not you're unable to come to work, or you don't think you should come to work, that's certainly a conversation that you should have with your either your primary caregiver or with occupational health. They can certainly help with that at UHN, and are doing that for a lot of people at the moment. So you're not in a small group there either.
Thanks, guys. Next question. Some employees think that once they're vaccinated, they'll be allowed to return on site as normal. Can you communicate to all staff any precautions that will still need to be taken even after they're vaccinated? Is there also a plan to returning to on-site operations once everyone's vaccinated? Brad?
Yeah, so you're absolutely right. The vaccination in the clinical trials has been shown to be extremely effective, preventing 95% of COVID cases, but 5% still, are at risk. That's 1 in 20. That's not a small number. And we certainly would not change expectations of behavior after vaccination. So everyone is advised to continue practicing all of the same measures to limit community spread, whether that's PPE and social distancing and working from home and so on. So nothing changes. The other thing that we don't know a lot about is the degree to which vaccinated individuals could remain susceptible to infection and ongoing transmission without developing symptomatic disease. The clinical trials used endpoints of developing symptomatic disease, and there isn't a lot of data around whether or not individuals can remain infectious. So without that data, we treat everyone the same way as a potential risk, and that behavior should follow that. As far as returning to normal, post-vaccination, it's going to be really driven by community spread. So vaccination has 2 roles. It's to protect you, which this vaccine does a good job of. It's not perfect, but a good job. And it's to also drive away the disease. And that's the real, benefit, is reaching herd immunity, removing enough hosts for the virus so that it disappears. And that's when society will really come back to normal, is when COVID is largely gone and the community risk becomes very low.
Thank you, Brad. So we're going to skip the next PR question just because Brad already answered it. And the next question is, will UHN be providing the Form T2200? And I think this one's for Lisa Murphy too.
Hello again. So I know many of you have been asking this question on many of our forums, and you may have seen the updates that the Canada Revenue Agency has provided to simplify this process for those who are working remotely. So, they have designed a shorter way or a shorter form to to claim home expenses for the calendar year 2020, up to a maximum of $400. And they have outlined, how you go about determining how much you would be eligible for. And in addition to that, they, if this method, if you want to explore a more detailed method, there is also a short form that is also available for completion as well, that also walks you through in terms of what eligible expenses you may be eligible to claim for. That information and the link is on the payroll HR intranet site, and I believe we're going to include the link when we do the recap of the forum. But just in terms of people also want the T2200 form completed by the employer, we are working with some of the other TASN hospitals to understand how they're managing that process, and we will be communicating something out in the very near future. So stay tuned on the specific T2200 form, but you can also consider just the quick method, if you will, in terms of claiming expenses. Thank you.
Thank you, Lisa. The next question, I guess, is really more of a statement. I feel really guilty about getting the vaccine before some frontline staff. Vaccine slots were open to anyone who sees patients, and I booked without knowing how many essential high-risk staff were yet to be vaccinated, and I'm sure I'm not alone. Brad, could you comment?
Yeah, so this is in terms of our own clinics. The clinics were opened up to patient-facing staff at one point when we still had vaccine, and that was really done because we had more slots than bookings. So there are some frontline staff, those in emergency departments and ICU that unfortunately haven't been able to get in. This has been in part because of the booking process. which was sort of a first come, first serve, the opening up of a URL, and you had to be at your computer at the right time and so on. So there were inequities of individuals who just didn't have the chance to get in there that were deserving, of course. So you should not feel guilty. The vaccines, once they're opened and drawn and diluted, need to be used. We have to make sure those slots get filled, and that's why it was opened up, and that's a decision UHN made, and it's one that certainly you should take advantage of when you have the opportunity. What we're doing now is going back to make sure that we can get to all of those that really want the vaccine, that are part of those high-risk areas. The registration process will make sure we have a complete list, and can do a targeted booking or a dedicated booking going forward. So I'm glad you've got it. You're part of the solution to this problem. So I think once the vaccines become more readily available, these issues are going to diminish in importance. So.
Thank you, Brad. Next question. Brad, people were upset about overseas travel by some in research leadership roles and committees. Can you comment on how we should go forward positively?
Yeah, thanks for the question. This was also something that was addressed in the town hall, the UHN town hall. It was addressed by both Kevin and by Keith Stewart and others. I think the lessons from that are looking forward and moving forward positively. We've given advice to all of UHN to follow the guidance set by our governments and local health officials, and our expectation is that everyone follows that advice. So that remains the advice and the expectation, and I think it's something that will certainly especially in UHN leadership, be adhered to in a way that everyone would expect.
Thanks, Brad. We are past the hour mark at this point, so I'm going to leave it to you to wrap up.
Okay, well, thanks. So thanks again, everyone, for joining. It's important that we recognize that there are both challenges ahead over the next 8 to 12 weeks, as well as opportunities that are going to come after that. And I want to thank everyone for their continued commitment to UHN, their commitment to helping us stay safe. And we look forward to a time where we don't need the COVID-19 town hall, but until we do, I am happy to continue interacting and engaging with everyone, answering questions. We'll schedule the next town hall, I think, in 2 or 3 weeks. I'm sure there's lots of questions still. We didn't get to them all this time, but we're certainly happy to do so. And if you want to reach out before then, if you've got any questions before then, please do so as well. Anyway, until then, take care, stay safe, stay home, and I would look forward to brighter times ahead.